can you just introduce yourself, a bit of your background, and then just really briefly, what's the biggest challenge that yourself or your organisation has faced with COVID? You need to unmute, Claus.
Yeah, okay. Okay, my name is Claus Klingenberg. Thank you for inviting me for this excellent webinar. So I'm the lead consultant in the NICU in the northern part of Norway, in Tromsø, which is situated far above the Arctic Circle. So it's high up and quite remotely, sparsely populated region. And I've been working there for many years, but I've also been abroad in Australia for a while and been to some other countries, working also mainly with infections and neonatal infections and antibiotic resistance issues. So for me, like the lead consultant in this unit, the kind of the biggest challenge we had to try to organize everything with kind of restrictions issues and infection control issues in the unit, because we didn't have many patients, but we had kind of to change kind of organization issues around deliveries and around precautions in the unit and visitor restrictions. So that were mainly the biggest challenge initially in this phase for me, and also to address guidelines.
Brilliant. Thank you very much. I'll move on to you, John.
Sorry, yes, thanks very much for having me. I'm John Zupancic. I'm a neonatologist at Beth Israel Deaconess Medical Center in Boston, and the past chair of the section on neonatal perinatal medicine in the American Academy of Pediatrics. I think that probably the biggest challenge we've had is around uncertainty and trying to come up with on the ground frontline policies that not only reflect our needs in the context of the care we're providing, but we're also consistent with recommendations, with national and international recommendations. And that was a daily task of reconciliation. So we'll talk about that more, I think, from several of the speakers, but I think that challenge of trying to figure out what to do in many domains and ensure that it was informed by the evidence that and expert recommendations was really a full-time job.
Thanks, John. Anna, I'm going to move over to you.
Okay. So thank you very much, Damian, and thank you for the organizer to inviting me to this webinar. I'm Anna Lavizzari, and I'm consultant neonatologist at Fondazione IRCCS Granda, Ospedale Maggiore in Milan, which is the second largest NICU in Italy and the largest one in my region, the Lombardy, that, as you know, was the most affected region in Italy for the COVID-19 pandemic. I have a special interest in neonatal pulmonology, but in the last months, thanks also to John, Claus, Charles, and Eleanor, we started working a lot also on the COVID-19 issue. And I have to say, Damian, that for us, luckily, the main issue was not a clinical issue. We had a few positive babies, and we had a lot of babies born to mother positive for SARS-CoV-2, but luckily they were only mildly symptomatic or completely asymptomatic. The issue was more the para-COVID effect, meaning that we had completely to change the shape of our hospital, completely change our organization, learning new procedure, very complex procedures for donning and doffing. And of course, there were also some other difficult effects on our daily life, such as the restriction to the access to the NICU for parents. This was really something very difficult for us. And you also have to imagine that all healthcare workers working in NICU at the same time had relatives and family sick, maybe hospitalized, or that lost their job. So it was most, I would say that the main issue for us was more the para-COVID effect rather than clinical issues in newborns.
Brilliant, thank you very much. And last, Charles.
Yeah, thanks. Well, let me say I'm really excited you're putting this together, and thanks, Damien, for your moderation, and thanks to Cynthia and to Eleanor for giving this the platform. It's really important to learn from my colleagues. That's how we got together and started, because we all had different questions. Now, all the aforementioned questions I won't repeat. For me, the biggest challenge was to give guidance on a national, international, and local level, faced with all the uncertainties. And we all worked really hard, but as my colleague said, it's because of the great uncertainty, you just went round in circles all the time, and getting some kind of evidence was the biggest challenge.
Excellent. Thank you. So, I mean, what's really nice is there's clearly some common threads, but I think there are those threads are also in some separate domains. So we've got things about how you deal with kind of infection prevention, what you do with guidelines, how you manage uncertainty, and what is the effect of COVID on other places, which then affects you. And last but by no means least is the effect of COVID on families. It's really important that we don't kind of forget that. What's fascinating is no one talks about loads of clinical conundrums because there weren't any, because not that many patients were affected. And that's the same in kind of my sphere in emergency medicine. And that's been one of the really interesting things about this whole COVID pandemic for pediatrics, including neonatology, is how children are sparsely affected, but it's still having a major impact. And how we learn on that, I think, is really important. So I'm going to go back to you, kind of, Claus. So just to pick up on, so you've mentioned some challenges. So what are the things that you've done to mitigate against those challenges? I think you talked a bit about kind of infection prevention and guidelines.
Norway is a small country, so we actually managed to get the national guidelines quite quickly within the National Neonatal Society. And that was great because we managed to collaborate and have some kind of common ways of dealing with this, and in particular with what should we do about breastfeeding and isolation, because there was a lot of attention around this, and there was a kind of an urge that we maybe should separate mothers, and I think in aftermath, we are happy that we didn't go for that kind of separation, because someone were urging that we should do it, but we were kind of trying to be a bit reluctant to be too strict, too kind of strong on extreme infection control without any kind of evidence. So the kind of the collaboration within the country of Norway was very good, and that was kind of a big advantage for the whole country, that we managed to draft common guidelines. I think that was one of our best kind of efforts in this early phase of the situation. Yes.
Excellent, thank you. So John, you talked a bit about, I think, about uncertainty. How have you tried to mitigate against that?
Yeah, I think at the local level, probably two ways. The first is to be out in front of the issue and to be nimble. So we were meeting essentially every day in various configurations, and trying to update our guidelines really in real time based on what was coming in from people who had already faced the issue, like Dr. Lavizzari, from WHO and from national organizations. So we were constantly trying to make sure that our guidance to our staff reflected what they were going to be hearing elsewhere. Getting out in front basically meant pre-warning the staff at the beginning of this that things were going to be changing fast and that there was uncertainty. If we don't do that, then it becomes really confusing, because I think in medicine, generally guidelines come down, once a year or once every 3 years. And here they were literally coming every.
John, I've lost you.
Well, the babies are, did pretty well. We didn't know that at the very start of all this. And then the second thing I just quickly add is to be part of the conversation nationally. So when things came down that didn't make sense to us, we were encouraging the members of the section, for example, on neonatal perinatal medicine, to write in and say this isn't what we're doing, this isn't what is happening elsewhere, and trying to be part of that of revising the guidance.
Thanks, John. And one of the interesting things is about this mobilization. So I think we've got a lot to learn. Think about the last time major guidelines were drawn up and how long it took, and then how quickly guidelines have been produced because we have to do it. We are very slow at doing things, and that's not just neonates, that's across the board in medicine. And I think we've got a bit to learn from that. Anna, so you mentioned a bit about para-COVID effect.
Yes.
How have you managed that?
How we manage that? Well, I have to say that it was also a little bit of improvisation. As John said, there was a lot of uncertainty, and we had to learn every day for what has happened the day before, and also trying to correct our practice based on previous experience. Of course, the fact that also the Italian Neonatal Society produced guidelines was very supportive for us and for other NICUs. Something that was also very useful, I think, in Italy was that we tried to centralize care, meaning that for each province there was a tertiary center which was identified in order to send at least the more complex pregnancy or the most complex cases of COVID-19. And then, as I said before, luckily we didn't get very many. And then it was also, unfortunately, we could not have a lot of psychological support during the pandemic time, because we had a restriction of the access to the NICU also for medical students and other not considered essential figures, such as also psychologists and researchers or other collaborators. And I think that this probably we should have taken more into consideration, psychological support also for healthcare workers.
Yeah, no, thank you for that. I'm going to come back to kind of psychological support and well-being, because I think it has come up quite a bit. Charles.
Yeah, so I said one of the challenges I faced was giving guidance, and writing guidelines is one thing, but to find out that there's literally no evidence to base them on is another. And unexpectedly to me, and very, very, very surprising, the UK government helped us set up a national trial on COVID. And from back of a napkin to first inclusion of a patient was only 9 days. And the recovery trial is now included more than 12,000 patients all over the UK, investigating a series of medications for hospitalized patients. And we also have a neonatal arm. So I'm very fortunate that my department started pushing this out, and I'm the neonatal lead on this. And although, as Claus and the others have said, Anna in particular, neonatal disease is rare and mostly mild, we do oversee a number of patients, young patients, that are quite significantly ill, and I do hope that we will be able to form some kind of knowledge base with our endeavors, and it's great to see that, as you also said, Damien, you know, when needs is great, then people really show their greatness, and this is a time that we live in, and we encounter this often.
Is there anything, I mean, the recovery trial has clearly hit the news because of the kind of finding for dexamethasone in adult ICUs. Is there anything else you wanted to add on recovery from a neonatal standpoint? Or is it just too early to comment on anything yet?
Numbers are very small, and it's too early to comment. But as yesterday's news was that for adults, dexamethasone will become a base part of the standard of care. It is reasonable to assume that positive anti-inflammatory effects will also be seen in young children. Dexamethasone, of course, is a drug that neonatologists would be very shy to use without good evidence. But we also have hydrocortisone for neonates and for very young, for the first weeks of life. So let's wait and see. But I think anti-inflammatory treatment seems to be the key for patients with an oxygen requirement.
Excellent. I mean, I think if we've got time at the end, there are some wider, almost ethical and research governance debates. I know in my kind of particular social media academic circles, there's a lot of unease about how quickly this dexamethasone change has come out given the fact that we've not seen a peer-reviewed publication with the findings in. Now, I suspect it is beneficial and everything's hunky-dory, but it does raise some eyebrows. Okie dokie. So what I'd like to do is now think about, so some of these things we may have already covered, but I'm going to go back to you, Claus. What has been the big surprise for this? What has happened, or what have you learned that you just wouldn't have expected a couple of months ago? You've gone, wow, I didn't expect to find myself doing this.
Oh, it's a difficult question, but it's kind of, we didn't know how this disease would affect children, although there were some indications already from the previous coronavirus epidemics in MERS and SARS-1 that it wouldn't hit children very hard. But it was kind of a surprise that it's not being at all very severe for children. So we have done a lot of kind of infection control measurements, and we have made guidelines, but we haven't really been using them too much yet. And we have used a lot of time to reassure nurses, parents, doctors about that this might not be so scary. And what has sometimes surprised me a bit is the kind of extrapolation of data from adults into neonates and children, where there is definitely very dangerous for adults. And some people tend to kind of extrapolate that this would be, assume it would be similar in neonates and children, and it hasn't been. So we should be very careful about kind of taking data from the adults into neonates and just doing the same things, applying the same drugs, applying the same infection measurements, because it's definitely a different disease in children and in neonates in particular. So that is kind of a very important message, I think, to the society, that some diseases behave very differently in different age groups.
Yeah, excellent. Yeah, thank you, John.
It is a difficult question. I think maybe the most surprising thing for me was how quickly care delivery systems can actually adapt. So in the United States, we've spent years trying to get telehealth rolling. And literally within 3 or 4 weeks of people starting to shelter at home in the US, telehealth was not only approved by governmental organizations, but essentially universally adopted for to prevent, contact for elective or semi-elective interactions with patients. And in neonatology, we adopted it wholesale here for antepartum consultations, which were essentially information giving and discussions around often issues that weren't going to be actionable for weeks or sometimes months. And it actually turned out to work really well. And so I think that this idea that there are things that we can overcome very quickly if we put our mind to it was surprising to me. And some of those things I think are good. I think the idea that we can come to where parents are without them having to drive for 2 hours for a 25-minute conversation is actually wonderful. And so there are silver linings to some of these delivery issues, and that was positive.
And I mean, excellent. It doesn't make you wonder why we've tolerated some things for so long. And I think that is a big pause for reflection. And there's a few things that we might get to about some of the practices which have changed for the better. Because I think there are a lot of silver linings in what's happened as part of this pandemic, amongst kind of obvious tragedy as well. Anna?
Yeah. So the entire fact of the pandemic was pretty much unexpected, was just something that we read on books, on medical books, or we watched in movies. And at the beginning, when I saw the number of positive cases and deaths rising so fast, so sharply, I really worried about my country. But I have to say that the colleagues from the ICU did a great job, did an amazing job. And I was really astonished how good they could manage the entire pandemic here in northern Italy. And I think that the key of their success was that they have a very strong network, and they were really able to make a joint effort to fight this kind of catastrophe for our country. by contrast, on the territory, medical general practitioner were less to support, but I think that this was also an issue due to our politician. So one of the main learning from this pandemic for me was really the need of work together and have a shared approach. And this experience with Claus and John and Charles and Eleanor of creating a consortium, of creating a group to discuss and share our experience was extremely worthy. This was really the first time also for our hospital where we were all in the same situation. All the medical figures were fighting against the same enemy, against the same issue.
Oh, thank you. And there's starting to be a few questions coming through, which I'm going to hang on to for the moment, but we'll come back to a few of them. So, Charles, unexpected or kind of novel things from your end?
Yeah, so unexpected was really the complexity of the problem, and us neonatologists, we're always sort of somewhat stuck in between a rock and a hard place. You have the obstetricians who had to deal with great uncertainty and the perinatal management of mothers positive or suspected with COVID. And then further up, it's the pediatric department who had to deal with our patients possibly moving through hospital. So the many layers that we tackled with brought a lot of positive also, that we have learned on an organizational level to be much more understanding of each other's challenges, and quality improvement projects, which I've started before COVID and halted during COVID, are just beginning to start again. And it's you know, if you'd asked me 6 months ago how long certain things would take, I would give you an estimation of 3 times the length of time it takes me now to move things between departments, just because thankfully we learned to listen to each other, and we spoke with each other more frankly and frequently also.
Yeah, I mean, it shows you in a world that has become more isolated, we're actually more connected. There's a subtle kind of weird irony and yin and yang to that. So I just want to kind of pick up that the mantle of kind of learning, and are there any clinical or educational or research practices that you've picked up during the last couple of months that you're going to take forward? So, Claus, is there something that you've started doing because of COVID that you're going to continue doing after COVID?
We haven't been really very hard affected by the COVID here in the north of Norway, and even in Norway in general. So we started national projects, but it has been really hard to recruit, and it has been mainly a problem that we had to stop other projects. So, and then we have waited for the COVID patients who didn't arrive. So it has been a kind of a troublesome time for other research projects due to the kind of all the circumstances around this situation. So I don't know, I think in our situation, starting COVID-19 project, we would be far behind. We don't have the numbers, so it's hard to get into those projects. We have definitely been better with infection control in units, I guess. And maybe we think more clearly about visitor, not restrictions, but we are more clear about how to do the infection control with parents in the unit. And that will be important to maintain even after this pandemic. Hopefully will fade out in a while, but that's kind of maybe the most important thing that we have achieved. And then also the national international collaboration that has improved definitely, which I think, which I like a lot. It has been easy to connect to other people, discuss things, and try to make rapid changes in guidelines and not waiting for days and weeks and months and years. So that has been a very good situation, I think.
Yeah, excellent. I mean, it was interesting. So when we did a call like this for a US audience, and someone was saying that just because of the infection control measures that have come in for COVID, they've removed some of their more resistant organisms from the unit, which is an unexpected but very nice kind of positive outcome. And it shows you how important infection prevention is. And if you do it really robustly, it does make a big difference. John, so you mentioned previously a bit about kind of, well, you might keep the teleconferences for patients coming for antenatal visits. Anything else?
I think the other one is, the other thought I have is kind of at the other end of the spectrum, and it echoes something that Claus just said about the platforms for international collaboration. You know, the leadership that Charles and Claus and Anna showed in putting together this collaboration that just resulted in the guidelines paper in pediatric research that you mentioned, seems to me to be something that we should be doing permanently. So we don't have a neonatology specific international collaboration, and I think that the folks on this call have started to talk about that, some sort of permanent structure by which we can speak to each other, either within one of the international pediatric association kind of venues, or on its own. I think that's going to be really important, because presumably there are going to be other global issues that we're going to have to respond to on behalf of mothers and babies, and doing it as we have in silos that then might come together at ESPR or SPR or so on is very different from doing it de novo as a group and bringing in real time the knowledge that you have from in different countries. So I guess I would like to see us make a real effort to create that and to take it forward. And I'll let Anna and Charles talk more about that, because I know that they've thought about it quite a lot.
Excellent, thank you, John. So I'll move on to your kind of same question, Anna. What have you learned that you want to keep doing?
So something I think very good that we did was to keep mother and babies together as much as possible. If both the mother and the babies, even if the mother was positive, were pretty good, they were staying together, isolated in the same room. And we taught to mother how to breastfeed, taking hygiene precaution. And actually, we didn't get any babies, only one who got infected from the mother, just because they stayed together. And this was a particular case. The mother was very sick. She had already previous comorbidity, and I suspect that she also had a very high viral load. But I think that keeping mother and baby together as much as possible is a good thing, also for the health of the baby. And something else that we learned, I think in Italy, is to discharge maybe a little bit earlier mother and babies compared to Norway or other northern countries. We still keep babies in the hospital for at least 48 hours. And at the beginning, we wanted really to discharge faster, also to avoid a high number of people in the hospital, but also because we had kind of limitation of beds because of getting more and more COVID positive patients, and for the issue of creating new isolation room. And so we learn also to educate mothers and allow them go home earlier, but still being there in case they need it. So I think that this is also something that we learned, to be maybe a little bit less assistantialistic. I don't know if these words exist in English.
That works for me.
No?
No, it's fine. It'll do.
It's fine. Yeah. And give to people responsibility, but still demonstrating that you're there in case they need.
Excellent. Thank you. Yes. And Charles.
Yeah, thanks. What always surprises me, and you know, today morning I had a seminar online where parents were present, and we learned how parents dealt with this situation. And believe me, even though we thought we do our very, very best to communicate, even any good day, in particular in a pandemic crisis like this, it was shocking to see how parents did feel left out, fully understanding the pressures that we worked under. And if anything, this situation brings to mind that we have still lots to learn to really engage parents as partners. And I could start with this from making guidelines and guidances to how we introduce them and how we keep them up, on the unit, and that's one of the things that I've really learned that I need to take forward, and I think this parent partnership is something which particularly neonatology is eminently set out for, and we need to be much better at it. That's what I want to expand on.
Excellent. Yeah, thank you. It's a lot of reflection to be done, I think, across the board about that kind of the co-production, co-collaboration with families. Okay, I'm just going to take there's a Rangasamy Ramanathan just asked a few questions on the chat. I'm going to go to you, Anna, next. We heard kind of from outside of Italy about ethical or potential ethical conflicts because there may not have been enough ventilators for all the patients who needed them. Now, I'm sure that wasn't the case in neonatal practice, but is that something that happened in your hospital? Because I can see that creating a bit of a moral dilemma, clearly important for patients, but also for clinicians. And you mentioned a bit earlier about this well-being. So how did you approach some of those challenges, and what did you learn from them?
Well, as I said before, I'm really proud of my colleague from the ICU because they were really very well organized. They had a network, so all the ICU in Lombardy were in kind of communication. They were sharing patients and also ventilators and materials. Then there were a lot of, maybe fake news circulating, but in our hospital, they stopped all non-urgent surgery. And they were really able to manage, also the amount of ventilators. We bought some new ventilators, but we were able, for example, to close some or to use some ventilators that are generally used in the pediatric ICU for adults. So I think that we really didn't get in trouble for this, or I never heard anybody using one ventilator for two patients. This didn't really happen. But I think that they were very good in organizing how to manage resources.
Excellent. Okay, thank you. So Claus, you mentioned you actually there weren't that many cases in Norway, but I'm presuming that you had to change some of the way that you did business, especially around kind of infection control. So I think someone has asked, have others seen a fall in MRSA rates during COVID? Have you seen any difference in other infections or kind of other outcomes during the pandemic?
No, we haven't really seen that in neonatology, but we have seen it clearly in pediatrics that there are less airway respiratory tract infections. So it has been very quiet in the pediatric ward after this kind of pandemic started, because the kindergartens were closed and schools were closed, and it was clear that there was less respiratory tract infections around in the society. So, and we had less admissions to the pediatric wards. In neonatology, wasn't that affected, and we didn't have that high kind of antibiotic resistant bug rates in our unit anyway. So I haven't really been able to observe that, but for pediatric, it was clear that this had a massive impact on the general infection rates.
Okay, thank you. I mean, interesting. Cynthia's just kind of added that she's actually have been recently a 34-week baby who had MRSA sepsis and osteo. So things can swing both ways, I suppose.
Yeah.
John, kind of a similar question to you about, have you seen any non-COVID related outcomes in your unit just because of changes of practice?
We've not at the local level. There is a US version of a registry and of maternal newborn dyads whose mothers had positive coronavirus testing. And there are some interesting issues that have come out of there. I think one of the most notable is that it relates to the idea that crisis shines a kind of a harsh spotlight on the holes that you have in a system. And in the US, we're seeing some signals that, for example, people who were disadvantaged prior to the onset of COVID have actually borne the brunt of the disease burden of COVID itself. And so one of the things we've seen is basically worse outcomes for people who are already disadvantaged. And I think we're going to in coming months potentially see that isn't just COVID related issues, but broader issues of newborn and infant health. Are they less likely to go for follow-up visits, less likely to get vaccinated, more likely to get vaccine-associated diseases? I think that's what we're going to see. We haven't seen any locally, but we have documented that in this registry, which now has about 1,000 infants in it, that the incidence of COVID is almost twice what we would expect it to be, or there are twice as many babies in the registry of who were from disadvantaged populations than we would have expected. So I guess that's what I would say. It's kind of a bigger picture warning rather than anything local that we've noticed.
Yeah, thanks for that. Yeah, it's interesting. Charles.
Thanks. So I've been fortunate enough not to be too much on the shop floor in the last 8 weeks. And I honestly can't give you the figures for Oxford. I suspect it's very much in the sense like Norway, because we luckily have been spared the extent of the pandemic as, for instance, London or Manchester or other more densely populated regions in the UK. So no comment on that respect. But if I may, I read the questions, and one question from Cynthia relates to research. And I just know we have very little time, but because this is a pediatric research seminar, I'm very interested to hear how others see the role of research and the chances for research funding. You may know I'm the president of the ESPR. I forgot to mention that in the introduction, and I'm hugely interested to see how you guys all tackle the challenges that neonatology and pediatrics will face, looking at the next funding rounds, which I believe will be swamped with research. So I don't want to upset the agenda, but it's something that would be one of my questions.
That's a perfect. So Claus, so straight to you. So what does the next couple of months hold in terms of your kind of looking at research applications? Are you worried that everything's going to be COVID related, or that because people haven't been doing research, as Cynthia was saying that in our pre-chat, she's managed to get a load of grants together because there's been kind of not twiddling her thumbs, obviously, but having a bit more time. And are we just going to see massive amounts of competition now?
Definitely there's going to be a massive amount of competition around COVID research, and I'm not sure I would like to compete in that area because we don't have the volumes. Of course, it's a big concern that other research projects are kind of delayed, like we have a international project in Africa, which is severely delayed due to this situation. And that's my main concern when it comes to research. I think that many other projects cannot be kind of completed and cannot be kind of started due to this COVID-19 situation. I think it's also a big challenge with the COVID research that we would like to collect data from all countries, but there are lots of kind of personal protection service kind of people who are kind of making it very difficult for us to share data across borders, and that is, at least in Norway, a big concern. It's very hard to share data across borders because of personal protection laws, which makes it almost impossible to do it, even though they are rather anonymized data. So that's a concern when it comes to kind of this international collaboration on COVID-19.
Yeah, thanks, Claus. John, kind of same question to you.
Yeah, I guess it's this. The question gets at this idea of what is the appropriate balance of responding to a current societal need and ensuring that the background research goes on. It's exactly the same as the clinical issue of making sure that children are vaccinated, right? And there are important questions that need to be asked that might not have anything to do with COVID. I think that, you know, basically as a society, we just need to make sure that that there's some balance there, that research topics that are not related to COVID restart, and that funding doesn't get completely diverted by whatever the newest shiny object is. You know, as important as that shiny object might be to answer. What in a recent grant panel I was on, I saw that there was a lot of opportunism, and that the questions that were asked and the studies were at a, you know, more diluted level than they normally would have been. I suspect that, I just noticed something in the chat about the submissions of papers to journals with, you know, was going up, and I suspect that the quality of papers on average might have come down because of the rapidity with which people are doing things. So where does that leave us? I guess what I'm saying is that we just have the people who are in leadership positions, like some of the folks on this call, need to be very intentional and very explicit about the what the mix should be. I'm kind of in favor of a separate pot of money for coronavirus related research and continuing on the funding for other research topics, so that we can be very concrete about the fact that we're not leaving anything by the wayside, and any questions that also need to be answered for babies and moms.
Yeah, thanks, John. It's an interesting challenge. Does there need to be some activism from the research community to the funding bodies to say, look, okay, you can continue to do COVID, but we need pots of cash to continue what we've always done. Anna, any other further comments on that?
Yeah, so we also stopped or delayed some research not directly COVID related during the pandemic, and this was due mostly to the restriction to the access to NICU for other collaborators from other departments. In particular, for instance, I do a lot of research on respiratory support, and we collaborate a lot with bioengineering or other scientists, and so they could not have access to the NICU during this time. But we have also to be realistic. So we know that COVID for neonates was not that relevant. And so we need to carry on doing research on other issues which are much more relevant for our patients.
Thank you. So, Charles, there's some responses. Do you have any kind of reflections or feedback or other answers that you'd like?
I got a few answers, and I'm really grateful for this discussion. And John opens up a way out of this, and I hope that there's some sponsors who or national agencies who listen to the opportunity of setting COVID research aside with a limited fund and leaving other research projects open. And one of the research projects which I think we can talk about in this forum is the consortium which has come out of this, out of this paper really, or the paper's reflection of it. And I'm just intrigued, there's many more people in the calls now, what people think about the value of a preparedness, disease or disaster preparedness network in the neonatal field. Anna has been instrumental to all of us because she was at the European hotbed of the COVID wave hitting Europe, and her expertise greatly helped shape the guidance that I wrote for my hospital. So in general, I think my hope is that we will find a structure where we can move together closely for preparing for the next pandemic.
And yeah, thanks, Charles. So I'll let people on the call kind of mull over some of that. So we're kind of coming into the last 10 minutes. There's two things that I'm going to embed into one question for each of you. So one is there something that you wanted to discuss or learn about that hasn't come up so far that you're surprised about or just wanted to raise that I've missed? But also, and I think it just comes back to the well-being and mental health agendas, certainly as I'm a bit more than a young investigator, but I'm not quite a chair. I found the last couple of months really challenging because I think there has been some implicit pressure to produce stuff during COVID. And I found it quite stressful, not because the clinical work's been hard, but I think there's been some underlying tones. In order to kind of make your way ahead, you have to have done something during the last couple of months to prove that you're academically worthy. Now, I don't know if that's true, and that might be my own naivety, but I think that there is this undercurrent, especially in the academic fraternity, about that. And I'd just be interested in the panel's observations on that, and whether you've personally felt either under pressure or, if you're willing to be honest, about some of your own kind of your mental health and well-being over the last couple of months. Claus, if I can come to you first.
Okay, so there has definitely been a pressure on publishing, and I agree definitely with John that some of these publications are not very high level and not high quality, and that's a big concern because it certainly goes too fast in many of the journals, that there are some publications that are not really well peer-reviewed, and there are lots of examples. I think we need to also make publications to reassure kind of the public, the general public, and target also the general public, not only academic publication. We need to be kind of active also as researcher in the general public, because there has been a lot of concern around in the general public and parents and people in general. So how to deal with children and how to calm down the situation. So I think our responsibility is also to target that part of the population, not only the academic part of the population. And if you are going to do research, it should keep the same standard as before COVID, because it's definitely going very, very fast right now. And it's kind of, you can produce a lot of paper, get your names on lots of publications, but they are not all of them are at the same high quality level. So that's a bit of a concern, I think.
Excellent. Thanks, Claus. John.
So I guess two questions. Addressing the second one first, I don't think that our faculty has really felt a lot of pressure to get COVID-related papers out. There was a recognition, I think, that, because we were completely changing how care was delivered to babies, and we were so obsessed with making sure that we were keeping them safe and and interpreting the evidence as well as we can and keeping the staff safe and so on. Things basically just turned completely towards clinical care. And I think any involvement in bigger projects was seen, at least in my local situation, as kind of a bonus. It's great that you're taking part in the discussion. Keep it up. but there was still the need to have 3 or 4 meetings a day by Zoom to figure out how to tweak things, as I said. So I don't know if going forward, as the clinical demands have kind of come down, I don't know if that'll continue to be the case, or if people will start to say, oh, you really should reflect on this and start to think about what we can do. But I haven't had it as bad as what others might have had. The second thing I'll just quickly say that we didn't touch on a lot. You were asking, what have we not mentioned, and that's resilience of staff, and I don't have a whole lot to say about that. We put together a well-being committee, that tries to make sure that nothing is going on there that is having a negative impact on people's mental health, or even one step earlier than that, just the general morale, because we know that's an end in itself, and it's also associated with care quality. So I think that hopefully one of the other things that will come out of this in the future is that we'll be paying more attention to this idea of resilience and burnout, and even more than we were just before February. I think that's going to be important.
Brilliant. Thanks, John. Really important points there. Anna.
Yeah. So yes, of course, there was a lot of pressure on publication, but I have to say that at least here in Lombardy, there was also a lot of clinical pressure. So most of our clinicians were really working hard and not having much time for writing. But I definitely agree with Claus on saying that it's better to spend time for high quality publication rather than just publishing with very poor quality. And especially during this time, yes, I think that the fact that we were in the middle of a very dramatic situation, this helps at least me and other colleagues to find the balance between what is really important and what is not.
Yeah, thank you. Charles.
Thanks. I must say I really learned to love my employer because there was no pressure whatsoever, neither from the hospital side nor from the university to come out with, you know, an increased publication rate. There was a great emphasis on safety and, as you say, on mental health. And if anything, we grew together as departments. So thanks for that. And actually, on a national level, the funders, for instance, the National Institute of Health Research, extended all existing grants by 6 months without any difficulty. So there has been a nationwide recognition that these are very special times. So thanks to that. Looking forward, yes, I couldn't agree more. Rather quality than just sheer quantity. And again, I'd like to stress that collaboration is the key. And I hope we've moved together a little bit further as a profession and as a community of neonatal researchers.
Excellent. It's nice to end on the concept of communities. I mean, we've essentially come to the end of the hour. I just, Cynthia or Eleanor, I don't know if Eleanor's still here, is there anything else that you wanted to kind of comment on or finish up with?
This is Eleanor. I thought that was fantastic. Actually, thanks a million for participating. I really just wanted to see kind of forward movement on having an international collaborative neonatal network. We're one of the only specialties, I would say, across medicine that doesn't have one. And I think we're all worried that the next pandemic will disproportionately affect babies rather than adults. And we would be in a lot of trouble because we don't have these structures, but they're starting now. So it's really interesting to hear the panel's views on how we'd actually bring that forward.
Yeah, okay, so that's a neat little thing to finish with. So just, I mean, it's, do you feel, so I'll start with you, Claus, do you feel you're part of an international collaboration, and what can we do to operationalize that a bit more?
That's a big question. It's a very big question, because there are already lots of collaborations and national collaborations. I'm not sure how it's going to be organized, but it's definitely extremely important that we collaborate internationally, and maybe even stronger in neonatology. But we are also part of pediatrics, so within pediatrics we have already some of these organizations. So to start a complete new organization is a big issue. I don't think we have time to discuss that in total right now.
I would throw out one idea, in that the reason why we're on this webinar is that we're a member of one of the societies that pediatric research is the official journal of. And so there is some structure that ties together these three societies, which are international. It's called the IPRF. They oversee our fiscal management, and they've kind of pruned back to just doing that. But I wonder if there's some role that, because we're members of these three societies and we're linked through pediatric research, if that couldn't be the start of something more formal as an umbrella over all of us. Anyway, just throwing out that idea.
Yeah, cool. Thanks, Cynthia. John, anything just to...
Yeah, I guess just really quickly, I think I would echo Klaus's comments that it's a big deal to create a new society, and I think choosing another society to attach a formal neonatology subgroup to seems like a reasonable idea. Then you have somebody else taking care of setting up conferences and publicizing and so on, and you can concentrate on content. So I think there are lots of international collaborations, trials, and observational studies, and the sorts of things that we just did ad hoc. And I don't think it would be that difficult to get neonatologists together in one room, organization, sub-organization. It just requires will, and you know, I think we can do that.
Thanks, John. Anna, anything to add in?
Yeah, yes. So as I said during the talk, I think that collaboration is the key to succeed in front of facts such as this pandemic. But I agree with John and Claus saying that this collaboration needs to be structured in a smart way. Shouldn't be just something more, but probably we need to maybe better use the resources and the collaboration that we already have.
Yes, very pragmatic. Thank you, Anna. And Charles, I'll let you kind of finish up. Any kind of closing remarks on that?
Well, I like the idea, and I think we have existing conferences, etc. Eleanor is actually a founding member of the ESPR section, which deals with infection, immunity, and inflammation. And we've got our annual conference coming up in Barcelona as a virtual conference in October. So, you know, it would just completely fit the ticket if COVID-related research would be allocated in such a section of a society which mirrors you know, the AAP and the ESPR and the SPR in the US. So I think we've got the structure. We need to decide on what we want to focus.
Excellent, brilliant. Thank you very much. Well, I'm going to draw things to a close. Thank you for all the people who have just kind of joined in. We have recorded the this whole conversation, so we will be able to share that. So you might be able to share that with your colleagues once we've kind of edited it down a bit. I'd like to kind of thank Pediatric Research, and especially Eleanor and Cynthia for putting this on. But kind of most of all to Anna, Claus, John, and Charles for participating. I give really harsh rules at the beginning, is please don't try to talk for more than 5 or 10 minutes at a time, because people get a little bored. And I think they've been excellent at keeping to really concise, nugget-worthy comments. And I think I've certainly learned a lot, and I'm not even a neonatologist. So thanks for your time, everyone. I'm sure that we can do future of these, whether they're COVID or non-COVID related, and please do look out for them in the future. Keep safe, everyone, and we'll speak to you soon. Bye-bye.
Thank you very much.
Thank you.
Thank you very much.
Thank you.
Bye.